shouldn't actually be dilating it or accessing it. So let's start with what are we going to call the different parts of the artery. And I've outlined for you here the inguinal ligament, which defines when the external iliac is going to start moving posteriorly and into the retroperitoneum. So you always want to be below the inguinal ligament. And we'll talk about how to define that anatomically. But what I will say is now with micropuncture and ultrasound, don't forget you still need to palpate and find the inguinal ligament. And the way you do that is you put your middle or ring finger on the anterior superior iliac spine and the symphysis pubis. And your index finger will be somewhere around where the inguinal ligament is going to be. And then you fluoroscopically find the femoral head. And I want you to look at this cartoon here, because I've been teaching it wrong for the last 25 or so years. I've been telling everybody that you compress the artery on the femoral head, when in reality, actually, the femoral head sits in the acetabulum, and we're actually compressing on the pubis. So if you look at the area that's called the target zone here, we're going to see that again in a few seconds, that is the portion of the common femoral artery that you want to access. If you look farther down, you see the bifurcation and you see what is anatomically the common femoral artery, but that's not in a compressible area. So with ultrasound, if you are looking for just when you see the profunda and the SFA, and when that becomes the common femoral, and you stick right above that, you can be in a non-compressible area. So the important thing is to first palpate, then under fluoroscopy, use some sort of marker and find the femoral head acetabulum area. And that's the area that you're going to look for with ultrasound and micropuncture. So we'll go into more detail about this along with other things, but this is now to just recapitulate what we talked about the anatomy. But I want to draw your attention to the middle portion of the pictures here where you see the inferior epigastric artery. The inferior border of the inferior epigastric artery is where the inguinal ligament is. So the inferior epigastric wraps around the inguinal ligament, and its inferior portion is what you want to be below. I want to draw the distinction between the origin of the inferior epigastric artery and the inferior border. We often will take a picture and say, hey, yeah, that looks pretty good. It's right near the inferior epigastric. It must be outside of the retroperitoneum. Actually, you can be, as in this cartoon, just below the inferior epigastric and be in the retroperitoneum. So remember, you're looking for that lower portion of the inferior epigastric. So I think this is why it's important also when you first get your micropuncture in and the wire and you put your dilator in to take a picture. Because before you have placed your large bore sheath, you can define whether you're in an area that you're happy with. Okay, so this again shows you what the conventional definition of the common femoral artery is, and what the functional area is. For us as interventional cardiologists, we want to be accessed in the functional area because that's the compressible area. And you can see the sheath is entering at the right level, and you see the inferior border of the inferior epigastric artery, which defines where the inguinal ligament is. I personally think, and have for years now, I don't know what your standard practice is, but for our large bore access, I use micropuncture. In fact, all femoral access, I use micropuncture, whether it's a large sheath or a small sheath. And that's because sometimes I'm wrong. I stick the wrong area. I don't necessarily access the correct part of the artery. And you can see, even though the artery, the needles are not hugely different than one another, you can see that the change in size because of the radius is 50% or more bigger. And I don't know if you know this, but the Cook needle, the 18 gauge needle that we used to use standardly, that actually can be used as a scalpel. You can cut suture with it. It's got a very sharp and large enough cutting surface that you, if you are looking for a scalpel, just use the needle. Well, that's the good thing. The bad thing is that you can cut the artery, lacerate the artery, make substantial holes if you're in the wrong area. So I personally like to use the micropuncture. And for the femoral access, the correct angle is at 25 degrees, sorry, 40, around 40 degrees. And this can be modified based on the anteroposterior diameter of the patient. Obviously, in large patients, if you have a large AP diameter and you're going at the same angle, you're going to go farther in and you may be accessing deep. And the contra is true for the thin patient. On the right-hand panel, you see a picture of the SFA and the profunda, as well as the femoral vein. As I point out, we very frequently ultrasound are looking for 2 arteries and then 1, and then we stick there. There are 2 modifications that I'd like you to add to your repertoire, and that is to scan over, in this case, in the left femoral, over laterally, and see the femoral head. In most patients, the femoral head is visible, and you know, once again, as your second check, that you're at the level of the femoral head in a compressible area. Similarly, when you look and you see the femoral head, you make sure that you're not faked out by a large lateral circumflex artery. That can look like a sizable vessel, and you may think it's the SFA. And then you're going up higher, and you may access the retroperitoneum because what you thought was the SFA is actually the lateral circumflex artery, and now you've moved up too high. Okay, so here's an example of really seeing the needle go into the artery at 12 o'clock. And in this case, it's a stick where you see the artery is quite nice in this view, but you will also be able to see whether there's calcification or disease or posterior plaque. In some cases, when you see posterior plaque, you may wish to avoid that area or be careful when you're advancing the wire so as not to rough up the plaque. What I'll tell you is, as cardiologists, is we very frequently access in this common femoral cross-section, but the vascular surgeons very standardly access in the longitudinal view because they want to see the wire going in and actually not ulcerating or unroofing the posterior plaque. So I would suggest to you to practice both so that you can get facile. You also can see that there's an ultrasound needle guide in this case, which allows you to have the correct angle of attack here so that you're accessing the artery right where you've put your ultrasound probe. There are new ultrasounds that are in development that have both the common, the cross-section as well as the longitudinal view in one image so that you can look in both views at the same time. Okay, here are the steps of ultrasound access. I show you a CT scan, once again, that can give you some information. In this case, you see on the right femoral artery that the bifurcation is in an advisable area, but you see a very high bifurcation right at the inferior epigastric for the left femoral artery. In this case, we would probably choose the right femoral artery for the large bore access, or at least know that we have a high bifurcation. We often get the question of, well, if there's a high bifurcation, what should we do? Should we go higher? No, you don't want to be in the retroperitoneum, but if the SFA is sizable, you can still put a small sheath in the SFA because it's a compressible area. Remember, in general, we stay away from the SFA because when it is in the thigh, it's not compressible. But if we found a sizable artery in the right zone that we want to access, it's perfectly acceptable to access the SFA and to even use a closure device off-label if you are assured that you've got a good access site. Again, the CT lets you know if there's calcification. I showed you the high bifurcation here, and you also see the branches, in this case, the inferior epigastric and lateral circumflex. Okay, let's see this here. So in this case, you see a slightly high bifurcation that we saw in the CT scan. And you see with the small sheath that's part of the micropuncture kit, we take a picture and make sure that we're accessing the correct area. So some use what's called a dry closure technique at the end of the procedure, and also utilize a contralateral access to understand angiographically the common femoral artery and bifurcation, as we showed earlier. And this may be necessary in some cases where you're doing an urgent case, there's not CT images, or you just want to know what the artery looks like. And in this case, we're going to show what a crossover technique is, but you can put a wire down the common femoral artery, and that gives you a third method for localizing the artery, which is under fluoroscopy, you can see the needle and or take a puff and see. Okay, so here's an example of this. And you see that in this case, a distal aortogram has been taken, and you can see the SFA and profunda bifurcation, as well as some disease. Again, you're looking for an artery that is of suitable size, hopefully greater than 5.5 millimeters, and you're looking for the less tortuous blood vessel for your large bore sheath. This is an example of a wire being placed from the contralateral. So the access is here. An IMA catheter has been placed and a wire has been advanced. And now you see exactly where you want to stick the artery. Skip through here. And so we're going to go through in a little bit of detail of the Perclose pre-closure technique. You place 2 sutures before you've upsized the sheath. When the sheath is inserted and enlarging the arteriotomy, these sutures are still present and are there for when we want to close the arteriotomy later. And so we place the sutures when the arteriotomy is small, and then upsize the hole, and then we have those 2 sutures present through the case, and then close at the end. I personally place the proglides at 12 and 1 o'clock. The idea of rotating a lot within the artery and trying to pull it together at the end, I think leads to more damage to the artery, and also can, if you grab the artery too far away from the arteriotomy, you may actually narrow the artery when you pull the sutures closer. So I'm going to try to play this here. Here's an cadaver study where you'll see what is happening, in this case in the axillary artery. You'll see what's happening when a perclose enters the artery. So over the wire, the perclose is inserted. At the skin level, now this is dissection, but in the skin level, you'll remove the artery, advance the proglide in, and now you open up the foot plates. That's the number 1 that you see. And you can see that when you open up number 1, that the foot plates are now within the artery. And now when you push down, which has just occurred here, the needles go into the foot plates, and then when you pull number 3, the sutures are pulled through the artery. And you saw those steps there. And when the device is removed, you see now there's a suture, as well as the fisherman's knot there. And to remind you, the long blue one is the one that's the rail, and the white one is the locking suture. And you see there's a loop around the arteriotomy with the needle, with the knot down. and that will be enlarged with the larger access or tightened down at the end of the case. This is just another view of it. Incidentally, as I mentioned, this was the axillary artery. This is after removal of the sheath. So that's another thing to know, is that in a nice artery like this, a non-diseased, non-calcified artery, the artery will often recoil, and often the sheath arteriotomy size is much smaller after removal of the large bore sheath. Okay. So these are the two impella sheaths. One is 25 centimeters, one is 13 centimeters. It's 13 French for the 2.5 impella 2.5, and it is 14 French for the impella CP. I would advance this sheath over a stiff wire, either the one that comes with the impella kit or one of these three stiff wires can be used. It'll straighten the tortuosity and provide a better rail for the sheath to go in, particularly in large patients. I would make a nice dissection in the skin, as well as use this stiff wire, because if you use a thinner wire or a hydrophilic wire, such as a Terumo wire, you may actually kink the wire, or it may slide in the soft tissue and not deliver the sheath. So take that extra step in exchange for a stiff wire, even if it's been difficult to navigate tortuosity or to get up the common femoral. You can always put a catheter up into the distal aorta and exchange the wire in that way. So after closure, perform either, as we were describing earlier, a quick angiogram through either a smaller sheath or from a contralateral access. So what can be done is you pull out your large bore sheath, put in a 6 French sheath, and tighten the perclose down over that if you would like to take a ipsilateral angiogram. So how do we explant these large bore sheaths? A contralateral access, as we mentioned, or the technique of downsizing the sheath with the perclose to take a picture as well. And then we use the crossover wire technique that we showed earlier, and then you can advance in a balloon, hopefully the size of the artery based on the CT, and you can hook up your side arm of your sheath to pressure, and you can inflate the balloon until you see the waveform dampen or the blood pressure go away. And in that case, you will know that you're occlusive in the common femoral artery. And then with the balloon inflated in this dry closure technique, which I personally don't use uniformly, only on occasion if the disease is quite bad in the patient. But I'll tie down the perclose sutures, deflate the balloon, and see whether you have hemostasis. If it's not achieved, advance the balloon to the arteriotomy, inflate and hold some pressure. And then obviously a covered stent is the last method. So here's a depiction of this strategy where you see a crossover wire is being advanced. And then after the wire is placed in the superficial femoral artery, the catheter can be advanced and used to either upsize or advanced, and a stiffer wire can be placed in order to place a sheath. But in this case, you can remain with an 018 wire, and if you use an 035 balloon and hook that up to the TUI-Borst Y connector, as well as a contrast syringe, you can inject through the lumen of the balloon, because the difference in diameter between the 018 wire and the 035 wire will allow you to inject contrast and see what you're up to. And as we mentioned earlier, if this is not a closure situation, but rather an access situation, you can utilize the wire as a marker of where to access the artery. And you see that that's occurring in this case. Okay, again, to re-emphasize, make a large skin nick. Don't do it like an internal medicine doctor like us. Do it like a surgeon would, because you're going to be putting a 14 French hole in there, and you want that suture to be able to glide, no pun intended, through the soft tissue. Again, I use 12 and 1. Many people will say use the 10 and 2 o'clock. That's the first suture going in. And that's the second suture. And then I mark the first suture with a curved Kelly, and I mark the second suture with a straight hemostat, because I know that straight is the second. And that way I remember which one I need to tighten, which will be the first one first and the second one second. I don't actually know whether that makes any difference, but I haven't tried it the other way. And this is an example of inflating the balloon, and with the sidearm connected to the sheath, you'll see that the pressure waveform dampens. So remember, you will advance and pull back sheets with the dilator in, but when you inflate this balloon, you'll pull the dilator out so that you can transduce pressure. And as the sheath is withdrawn now to about 2 centimeters above the arteriotomy, you can take a picture of the arteriotomy either through the ipsilateral sheath or through the balloon to verify there's no arterial injury. And if there's bleeding, as we described earlier, common femoral artery, inflation and compression. You'll now deploy the sutures and see what type of bleeding there is. Again, you can inflate the balloon, or if you don't have a balloon, just hold manual pressure. And if there still is some bleeding, you'll have the wire in. One can either place another Perclose. My preference is to advance, depending on the amount of bleeding, a 6 or 8 French angioseal. I first insert the angioseal sheath and see if the bleeding stops. Then I know it was a 6 French hole, and I deploy the angioseal, and in most cases it's fine, but you don't want to look from the outside in only. You want to take your completion angiogram through the crossover sheath or from another access to make sure that you have a good result. There's no bleeding, and that you have runoff through the SFA and the profunda. And you'll remember what these arteries look like because you've taken a picture upon initial access with the micropuncture. Okay. Again, we talked about if there's not hemostasis, advance the balloon, prolonged inflation, hold external pressure. If all else fails, consider a covered stent. Again, you do not want to cover the profunda, which is why it's so important to not be accessed at the profunda, but instead to be higher so that you can land a covered stent and not have to be across the profunda if there's bleeding. Again, you want to size a covered stent 1 millimeter greater than the size of your common femoral, and then post-dilate at 1:1 to get good apposition. And remember that not all 018 covered stents go through 7 French, so you may need to plan ahead with what sheath you're going around with. Especially with TAVR, you'll already know what size that artery is. So here's an example of continued bleeding after Perclose deployment. And then after balloon tamponade and holding pressure, you can see that the bleeding has slowed down. You need to continue to hold external pressure because this continued leak, even though not catastrophic, will be what forms a pseudoaneurysm. So you want to actually compress and make sure this collection remains very small, and then ultrasound the next day. And again, a similar depiction of a balloon here inflated. After removal of the sheath, you can see an injection in the external iliac is not traversing the balloon, so we're occlusive here. And then after that, you can see that there's only the faintest amount of bleeding. Okay. If you find that there's a residual stenosis at the access site, I think it is up to the operator to decide whether with no bleeding, but it's somewhat of a narrowing, whether you need to dilate this to open it up. In most cases, we leave it if there's no dissection and there's no flow limitation. Again, another depiction of balloon tamponade. See a small amount of bleeding here. And again, this is where you'll want to compress so that this ooze stops and doesn't turn into a pseudoaneurysm. Again, here is damage to the arteriotomy. And remember, if your stick is in the right place, there can be extension of the arteriotomy tear superiorly, and you can still get a retroperitoneal bleed if you're in the correct area. So always be vigilant for this complication even after the procedure. In this case, a balloon was inflated to regain control, and a covered stent was deployed using fluoroscopic landmarks. The 018 wire was exchanged for a supercore, and in this case, that allowed delivery of an Ansel sheath, and then you see the covered stent here repairing the arteriotomy. Here's a dissection related to the Perclose and/or sheath advancement. In this case, there was probably a posterior plaque that was lifted up. Again, if you have already crossed from the other side, you need not worry that your wire is not luminal, and you can just inflate with the balloon at low pressure for 2 minutes. And just like in many balloon angioplasty results, it should be sufficient. This is the dreaded iliac rupture. And again, this used to happen a little bit more when the sheaths were even bigger than 14, 16 French. But now this type of complication is less common. But again, if your wire is already around the bifurcation, you can very rapidly advance a sheath and then a covered stent to repair and correct this problem. Okay, let's see if we can advance here. And this is what the artery looks like after covered stent placement. So in the last couple of minutes, I'd like to describe axillary access, not because you should go out and do this today, but because it re-emphasizes almost all of the techniques that we described just now for large bore access. And until you have mastered those techniques, you shouldn't attempt axillary access. But when you have, this becomes a very valuable tool. So just again, to review the anatomy, working from the brachiocephalic towards the axillary, there's the costocervical, superior thoracic, lateral thoracic, thoracoacromial, and subscapular. So the axillary artery is divided into 3 portions, 1, 2, and 3. You want to access the second portion of the axillary artery, which will be through pec minor. But these 2 branches, the subscapular and the lateral thoracic, define the second portion of the axillary artery. The reason that you want to access this artery is at least threefold. One is that the axillary artery in this portion of the artery is compressible. It is compressible. And the subscapular artery, if there is an occlusion here, has a robust collateral network. So even if the axillary artery occludes here, then the subscapular will be able to give blood to the arm, and you will not have an ischemic limb. In addition, when you access the second portion of the axillary artery, you're far away from the compartments as well as the brachial plexus. So if there's bleeding, you will not end up with a compartment syndrome, and you will not end up with a brachial nerve palsy. It's less frequently diseased than the iliofemorals. In the same patients, if you have a diseased iliofemoral, it occurs about 20% of the time in one series. But if those same people, there was only 2%. The average diameter, a way to remember it, is about 0.5 millimeter smaller than the common femoral artery. Okay, this is a picture of the collateral network that the subscapular artery is a member of. So even if the axillary artery occludes over here, you see that collaterals can come all the way around through the subscapular artery and serve the rest of the blood vessel. Okay, so I'll just point out now, if you look at this humeral head and you look at the glenoid cavity, if you rotate that 90 degrees, you're used to looking at this. And that looks like a femoral artery. And you again are accessing here in between these two blood vessels, again in a similar area, and you use the same techniques and the same bailout techniques that you would for large bore access. One modification is that you should be at a 25-degree angle, a more shallow angle, because there is a larger distance to traverse. So you want to be in that portion because the hypotenuse is a lot longer than in the common femoral artery. But again, you're using a micropuncture technique, using ultrasound access, and you may have advanced a wire from the femoral through the axillary artery and used that wire marking technique. And this is a depiction of that where you are now accessing through pec minor. There's a wire that has been placed here, and you see that you can access quite easily through the axillary artery in the second portion. But remember, if your angle is very steep, then that sheath has to traverse a very steep angle and can kink. So that's why the 25-degree angle for this access. And again, if your wire is actually tenting the artery, there can also be bleeding with a very sharp angle like this, which you can see in this angiogram, but which is also helpful to show you that if there is bleeding and you're in the second portion of the axillary artery, it's not going to be in the thorax. It's going to be out here. Okay, so again, you're going to access with a micropuncture and your double preclose technique. Here's an example. Again, in this case, we've advanced an 018 balloon. Here's an 035 balloon. And we can inject and see the artery. And there's a wire here, and we're using a micropuncture technique. And we've accessed the artery and the portion of the artery that we want. And in fact, we can inflate this balloon while we're upsizing and advancing the sheath. And now the balloon is withdrawn, and the large, in this case, impella sheath, the short sheath is advanced. I generally advance this sheath to the subclavian flexure and then withdraw the dilator, because if this has to traverse through here, there can be injury to the subclavian, and this is generally enough support in order to advance the impella. Here's closure. Again, you see bleeding at the arteriotomy site, and this is after balloon tamponade, which we described earlier. It should be very infrequent, the need to place a covered stent in this area, though it is perfectly fine. You're away from the internal mammary artery, and you're also away from the other important branches if your stick has been correct. But again, if you rotate that picture 90 degrees, this is not unlike what you're used to looking at on the common femoral artery. So key takeaways, you can avoid most femoral access and large bore access complications with proper access technique and case planning. I suggest that all large bore sheaths should be removed in the cath lab when you're removing an impella sheath or removing an impella for somebody that's been in the ICU for some time, I prefer to do this in the cath lab because we have all of the tools that I showed you available to you in case there's a problem. And again, large bore access closure and access requires knowledge of vascular closure devices. Many other devices are in development, so we'll see more in this area. You're going to be using more large bore sheaths as we do more and more complicated cases. And if you're participating in structural procedures. So one shouldn't forget the deleterious consequences of vascular access complications. There's a substantial increase in mortality if a patient has a large bore access bleed, and it often is the method or means for the beginning of a spiral of complications in our patients who are on ECMO or impella support or from TAVR. So it's very important to be very meticulous about this type of access. Large bore venous closure can be utilized for MitraClip. We didn't describe that or large bore access in that regard. Again, I suggest that we remove these things in the cath lab. And while we're radial first for diagnostic angio and for PCI, I think we should be well versed in these types of access techniques. And with that, I'll stop and take any questions. I would love to hear from you guys, particularly the fellows. Thank you very much.
Thanks, Dwayne. That was excellent. It was a really, I think, step-by-step approach to large bore access and hopefully exactly what the fellows need. While the questions are coming and Manaf is getting ready to answer them for you, ask you them, I have a couple of questions of my own that I wanted to ask. So I think, you know, what your presentation highlights is that even if you're not going to be doing structural and you're doing coronary, you know, more and more there's a need to manage large bore access, right? But also that these complications can occur even with 8 French sheaths at times. And so I think you highlight you need some peripheral skills.
I agree.
You need to know how to do crossover. You need to know the wires, the balloons, the stents. What do the fellows need to do? How do they get these peripheral skills so that they can feel competent just managing their own complications, you know, moving forward?
I think coming into the structural laboratory and convincing Dr. Latib that you will want to do a crossover technique or place a safety wire for this case. We actually, you know, look, we're often say, look, we're in a hurry. We want to do a quick case, this sort of thing for TAVRs, but we have a rule. If somebody has a BMI greater than 30, we automatically place a safety wire. That just avoids the discussion, and Dwayne wants to do it this way, and Dr. Latib wants to do it that way. We just have a rule. And that's a good way to then practice the crossover technique, which, as you point out, Azim, is something that I think all interventional cardiologists need to do. You need to be able to do this, and you need to be able to deal with very narrow angle bifurcations. You need to be facile with, I would pick 3 catheters that you cross over with and practice and develop your favorite, but be able to do it with others. And that's the OmniFlush catheter, that's the IMA catheter, and that's the RIM catheter. Those 3 you will cross over with. You'll use an angled glide wire to navigate the contralateral iliac, and then you'll advance that catheter in exchange for either an 018 wire, it can be a steel core, or any 018 wire that you prefer. And then be familiar with the Ansel family of sheaths in the different sizes. And then the rest of it, you guys know. How to do balloon angioplasty at low pressure, and then how to place a covered stent, and just be knowledgeable about what size covered stents go through with sheaths. And with that, I think that you will be able to handle 90% of problems that occur in the common femoral artery, even with an 8 French sheath complication or a 10 French sheath with a valvuloplasty or something like that you might be doing. And I would practice that during your interventional fellowship and go into the structural lab if you need to do that. Or if you know you have a planned Impella case, then plan on doing it in those cases as well. And if you need more experience, go into the peripheral laboratory and ask Jose to let you do this. And crossover occurs with almost every, runoff. So, this is where you'll build your skills.
Yeah.
It doesn't mean that you're going to have to spend 3 hours opening up a perineal artery so that someone's toe doesn't get cut off. That's super boring to me. And thank God for TAVR. But you can leave hopefully after the crossover has occurred.
Well, that's just like I can do an advertisement for our fellowship here. All the interventional fellows come to the structural lab, and so they learn how to do large bore access in the structural lab. So we kind of, one of the things that we made sure that happened now in the last year or two, because I think it's important, whether they do structural or not, it's skills they need as interventionists moving forward. One other comment, and then I promise I'm passing it over to Manaf. Just, you didn't mention, you showed an iliac perforation, and one of the, I think, devices you need to have when you're doing large bore access in the room, okay, is an aortic occlusion balloon. You need to know where it is, right? Because that iliac perforation that you saw, that Dr. Pinto showed, can happen. It's happened to all of us. It can happen, when we're doing an Impella, unfortunately. You need to know where the aortic occlusion balloon is, because if anything, you put up the aortic occlusion balloon, you occlude the distal aorta, and you call for help, and the patient's alive, right? Because these perforations patients can exsanguinate in a matter of minutes. So I always, try and make sure with these large bore access cases, we always have an aortic occlusion balloon ready. We know where it is, it's in the room, because it can save the patient.
Yes, I think that's important. And from a quality assurance standpoint, there are a number of situations that you have to be prepared for as an interventional cardiologist. If you're doing CTOs, you need to know where your coils, where your perforation management, coronary perforation management stuff is. So if you're a peripheral vascular interventionalist, you also need to know where's your perforation stuff and where are your covered stents. So what I would suggest is to have a disaster cart, and you already have all of the stuff that you need for when a disaster occurs. So all the stuff that I mentioned for a crossover, as well as the aortic occlusion balloon, it should be known where that is in the structural laboratory. It can be sitting in the corner and hopefully not be used twice a year, but everyone should know where it is. You could even make it part of the timeout. We take a little timeout before the valve is deployed, but you could put that in at the time of access or something of that sort, or when you're commencing your procedure, that our disaster card has been checked and available, and I would make it part of the room check as well. Ours and your radiation technologists, I'm sure, do a quality check of the X-ray equipment. It can just be another check there. Mm-hmm. So these are the types of things, because you're busy worrying about, is it a superannular valve? Is it a valve, coronary access, and all the things in the sizing, and are we going to put 2 cc's in and 3 cc's in? And you're not really thinking about, what happens if I rupture this artery, or if somehow a wire goes through the aorta or something of that sort, because frankly, we don't think that that's going to happen, and it doesn't happen until it happens.
Absolutely. Manaf, it's all yours.
Thank you, Dr. Pinto. That was a great talk with lots of great images, perfect for a new interventional fellow like myself. So thanks again for that talk. Question, I got to play a little bit with the MANTA closure device at one of the interventional fellows conferences recently, and or not so recently, pre-COVID. But I'm wondering where you think that will fit on the in the repertoire of vascular closure devices for large bore. If you think that'll be something that's here to stay, and where you see that you may use that type of device safely.
Mm-hmm. Yeah. So as a cath lab director, I don't like adding $100,000 line item $200,000 line item to the budget unless it's better. It's got to be better. So, you know, since each of these devices costs around $1,000, maybe a little more, if you're doing 200 TAVRs and you uniformly add this to every procedure, that's a lot of money. That's one thing. But if it is substantially better, then it's worth it, right? Because all you need is a few vascular complications, and the consequences to the patient as well as to the system are huge. But what I will say is we did a little bit of a natural experiment when we rolled out MANTA in our laboratory. We used MANTA in every single TAVR for several weeks, and then we assessed the complication rate. The complication rate was similar. There was a learning curve, no doubt, and many operators were learning. But after the learning curve, we still had a similar rate of complications, major and minor bleeding, as well as vascular complications. And the mode of failure was different with MANTA because you give up the ipsilateral wire. And so the need for different techniques that we showed, including balloon occlusion or crossing and placing a covered stent, were different than the Perclose, and more frequently requiring of more invasive therapies. So we didn't find that there was a substantial win by shifting completely over to MANTA. So what we use MANTA for now are heavily calcified arteries where the Percloses are not working, or where we think that the Perclose is not advantageous. Now, what that means is we're selecting the MANTA for worse arteries or where there's more disease. So we expect there to be more of a failure rate.
Right.
But I actually personally don't like giving up the ipsilateral wire. And I also, you know, want to make sure that that foot plate, which is quite large, so that foot plate, you know, is meant to close for the 18 French device more than a 20 French hole. So you can imagine how long that foot plate is. And if you're not completely coaxial, or it's caught on a plaque, or you're not pulling hard enough, then that foot plate may not be well opposed to the anterior portion of the artery. So that's a long way to say, I think we need better large bore closure devices, and we selectively use the MANTA. I've personally attempted use in an axillary artery, and I found that it was quite difficult because, as I mentioned, you have to traverse through pec minor, and that collagen plug going through there wasn't really going easily through. So I'd just use standard Perclose for axillary access.
Right. The question here about whether you use the pre-closure technique with the ProGlides in all of your Impella cases, even when you know, an unstable patient, et cetera. Do you find that the risk benefit changes there, or do you always pre-close?
Yeah. So, you know, sometimes time doesn't allow for pre-closure, or frankly, the person doing the Impella is not facile with Perclose. So the Impella is transferred from another hospital, or somebody who is not facile with pre-closure techniques put the Impella in. So in that case, we bring the person to the lab and we do a post-closure technique. There's a method to do this with MANTA, and there's a method to do this with Perclose. We described the MANTA closure in CCI, where if you don't know about the MANTA, you have to measure the depth of how far the skin is from the arteriotomy in order to advance the MANTA sheath in the right distance before you deploy the collagen plug and foot plate. Well, similarly, if you haven't planned ahead, you don't know what that distance is, or if someone's developed a hematoma or such. What you can do is actually exchange the Impella out, put in an 11 French sheath. Usually the artery recoils enough, and place a marking pigtail catheter and take a lateral picture, and you can measure that distance by counting the number of dots, which is 1 centimeter on the marking pigtail. if you're going to, and then deploy the MANTA device. If you're going to use a Perclose technique, then that 11 French sheath usually gets you hemostasis. And if it doesn't, you can always make it a little bit bigger of a sheath. And then you have one 035 wire in, put another one in. Now you have two 035 wires in, and put a 6, 7, or 8 French sheath. I personally use 6 French sheath, but the technique is described with an 8 French sheath over one of the 035 wires. So now you have a sheath in place in the arteriotomy. There's some bleeding and a wire in place. Now you advance your Perclose device in, and because that other sheath is in place, it's allowing the foot plates, like in the cadaver study that I showed you, to be up opposed to the arteriotomy a little bit better. If it was just floating around in a large hole, it may not actually be opposed to the artery. But that sheath in place allows that to happen. And then you deploy your sutures and you tie down. And now for me, with the 6 French sheath in, I just look at it. If it's not bleeding anymore, I know the hole is 6 French. I may actually take a picture, and at least in the end, I take a picture, but I may take a picture at this point and show that there's no bleeding. In which case, now I pull out the 6 French sheath and put another Perclose device or an ANGIO device over that 035 wire. I've removed the other 035 wire. So now I just do standard closure of a 6 French hole, and that's that.
Great, yeah. Another question I have for you, we recently have had to place an axillary balloon pump, and due to some angulation, I think in the arteriotomy, we lost some of the function of the balloon pump. The fiber optics weren't working. Do you have, apart from the angle of entry into the vessel, a laterality that you like to use the balloon pump versus Impella, considering the anatomy of where the devices have to go and the angle that they enter the body?
Yeah. So first, that fiber optic on the Teleflex balloon is pretty finicky. If you pinch it or move it, I think it fractures, and we've seen that in our hospital as well. And so we've actually stopped using the fiber optic until it can be redesigned. So I don't think it was anything that was, it's possible that it was something related to the technique, but it may also be related to the device. For the balloon pumps, I prefer the left side, although Raj Tayal, who's done many of these, says he's kind of side agnostic. But I'll just look at what type of arch it is, if that's a knowable thing. But some of these type 3 arches are difficult to get around the bend, even just putting the wire and such. So I like for balloon pumps to use the left side, but that's non-obligatory. For the Impella, I don't have a side preference either. With a large enough artery with the sheath placed at the subclavian flexure. There was a question I saw in the chat. I don't come around the flexure, but there usually is enough purchase in order to advance from either side. In fact, for the 5.0, which is a much larger device, we most frequently go from the right side and deliver it just fine.
I think, one of the important things that I learned from you early on with doing auxiliary impellers is if you go particularly with the impeller sheath past the flexure, it's going to kink on you. The minute you pull out the dilator, it kinks on you. And so you can get over it by using a stiffer sheath like a Cook sheath, but the problem then is you have to use a 16 French sheath. You can't use a 14 French sheath because the impeller won't fit into it. As far as the balloon pumps, one of the things I've been doing is, because it's an 8 French sheath, I've been using a slightly longer sheath, okay? And I put it across the flexure, almost till the arch, okay? And then have the balloon pump going through that, okay? And what that does for me is it stops any kinking that may happen at the flexure, but it also provides that support you need to really keep the balloon pump in position and stop it from migrating into the arch or into the ascending aorta. So that's something I've been doing too.
Yeah, the Super Aeroflex sheath, the silvery braided sheath, is what Azim is talking about, and that's been described to be much more beneficial at avoiding complications that Azim talked about. So that's what I would standardly use, not the one that comes in the kit or just that white one that is prone to kink. Impella should be coming out with a better sheath shortly with a hydrophilic coating and more kink resistance, but we don't have that yet.
All right. There was also a question on the chat about, other closure devices. So we didn't talk about ProStar. Okay. ProStar was the original large bore closure device. Many of us who started doing TAVRs, 8-10 years ago, when I was a fellow, that was what I was taught to use, was the ProStar. The difference, it's also made by Abbott. The difference is, instead of going from the outside in, you go from the inside out. So the needles are in the artery, and then you pull them out towards you. You pull out 4 needles towards you. And so you have, your 2 sets of sutures in place already. It requires that you start with a larger sheath, a 10 French sheath. I've abandoned using it. I think most people have, because it's just a little bit more complicated. More things, I kind of feel like more things can go wrong on using the ProStar. There's also now a couple of studies, published showing, they're not randomized. I think most of them are retrospective, showing that you have less vascular complications and bleeding with ProGlide compared to ProStar. And I think a lot of it is just the learning curve is so much longer with ProStar. Do you guys use ProStar at all?
We don't, Azim. All of us, we've really focused on trying to standardize practice amongst our operators. And so we honed in on the ProGlide, mainly because we also got TAVR well after you. So, you and I were, when you were describing your TAVR experience in Milan, that was science fiction to me, because I'd never really done TAVR, and I was hearing from you and you were describing your experience. So by the time TAVR came to us, we were preparing with Perclose and learning, large bore with valvuloplasties and such in that way. And so I just kept that,
right.
I never really got good at ProStar. And I think that's maybe something too for the fellows to take during this year is, if you're good at something and it works, you don't need to get good at everything unless there really is a need. For me, I'm pretty good at Perclose and I don't want to mess with it. I'm not going to have better outcomes with ProStar because I get pretty good outcomes with Perclose, and I don't think it would be better with ProStar. The reason, and as Manaf asked earlier, is, to even consider Manta is because the deployment is so much easier. There's not that learning curve, and it is more like an angioseal. And so I think it's more teachable, more disseminatable, but I don't think one should give up learning about Percloses, because that's always going to be something that you're going to need to know how to use. So get really good at Perclose.
Absolutely. And then maybe just a last comment on another question from the chat was the combination of ProGlide and AngioSeal. So there are a lot of centers in Germany in particular that have moved away from double ProGlide, and they put a single ProGlide and AngioSeal. Any thoughts, Dwayne?
Yeah. We actually very frequently do 2 Percloses, and if there's a lot of oozing or some oozing, we just put an AngioSeal in. I don't think 2 Percloses is obligatory for every case. I do think 1 is enough. For most Impellas, I actually have moved now to using 1 Perclose. It really is a belt and suspenders, frankly, I think, is that if one of the Perclose fails or as an imperfect closure, you have a second one. But obviously it doubles the cost and it doubles the chances of injuring the artery from the vascular closure device. But I do think we need better information. We need a formal investigation, I think. And maybe Monty and the VI are the ones to do it. But I do think that in the hands of good operators, one Perclose is fine. And if you're bleeding, put a second Perclose in or an ANGIO.
Right, right. I think, Manaf, I see there's one last question from Nelson. Maybe we'll just answer that one, and we'll stop the session.
Right. So the use of coverage stents in the common femoral artery as a bailout strategy, and some of the pitfalls, bifurcations, and things like that. If you want to briefly discuss that.
And also balloon expandable versus self-expandable covered stents.
Yeah. So just in general, the external iliac distal, you want to put in a self-expanding stent. Balloon expandable stents are good for aortoosteal disease. So common iliac arteries, renals, celiacs, mesenteric arteries, subclavians, those where you need a lot of radial strength are good for balloon expandables. But where there's an artery that's going to kink and twist and pull, like the SFA or the common femoral or the popliteal, you need to use a self-expanding stent. When you place a covered stent, you do not want to cover the profunda. So you have to be in a place where you're not going to compromise the profunda. It's better to send somebody to surgery than to cover the profunda. The other is, if all things go as planned, you will have time to deal with this. You do not have to immediately put in a common femoral artery covered stent, because you will have occluded flow and the patient will have stabilized, and you will have time to discuss the case with your vascular interventionalist or the vascular surgeon. And you must do this before you place a covered stent in the common femoral artery, because you are now eliminating a lot of options for the patient later. Now, this idea that the common femoral artery, because the patient walks around or bends at the hip, it will thrombose, is actually not actually the major concern. The major concern is, are you going to get adequate hemostasis? What's the runoff going to be? What's the chances of you completely dealing with the problem if there's a substantial dissection, or if the dissection extends into the profunda or the SFA? So you will throw this in without talking to somebody in order to save somebody's life. If there's some sort of catastrophe that you cannot control and you need to throw in a covered stent in order to stop exsanguination, that's pretty rare. But it'll be a discussion. It'll be something that you can do, talk to Jose, talk to whomever, if there's a problem, and you can know in some of these more advanced considerations of how to handle the bifurcation are necessary. But still know the technique, still know what fits through what, because you can say to somebody, okay, I want a 7 by 50, covered stent. And they say 50 centimeters. No, you say 50 millimeters. And, these sorts of things. And you can already place the appropriately sized sheath and all these sorts of things. So you should know about this, but it's a really good question, because this is not something you should be just doing willy-nilly.
Absolutely. That's a great point on which to stop. Not doing things willy-nilly.
Yeah.
Dwayne, thanks so much. We'll catch up soon. I'll give you a call next few days. Thanks
Okay,
again.
good.
Great session. I'm sure for all the new fellows and the more experienced ones like me, I still consider myself a fellow. I'm always learning. This was a great session. We really appreciate it. Enjoy the rest of your day.
Thank you for inviting me. Thank you.
Thanks, Dwayne.
Bye, guys.
Thanks, Manaf.